Hello and welcome to the FH Foundation's webinar on lipoprotein A or Lp(a) basics. My name is Kat Davis Ahmed. I'm Vice President for Policy and Outreach at the FH Foundation. And I'm just so pleased to have with us here Dr. Abha Khandelwal. Dr. Khandelwal is the Clinical Associate Professor in the Division of Cardiovascular Medicine at Stanford University Medical Center. Welcome, Dr. Khandelwal. Thanks for joining us. I'll do a few housekeeping items and then I will hand it over to Dr. Khandelwal to do her presentation on Lp(a) basics. So first I want to say this webinar is intended for your information. It's not a substitute for professional medical advice and does not constitute medical advice. And please follow up with your doctor or your medical team for any specific recommendations about yourself and your family. We would love it if you all want to join in on the chat and introduce yourselves, say hello and where you're from. We have people from all over the world and a really wonderful audience. And if you choose to put a note in the chat, please choose panelists and attendees so that everybody can see your message. We would love to take your questions. Dr. Khandelwal will field questions after her presentation, but feel free throughout the presentation to enter your questions in the Q&A, please. And we will get to as many questions as we can before the end of the hour. We would like to thank the sponsors of this program, our Community in Action program, Lp(a) Community in Action program, and that is Amgen and Novartis, as well as Konica and Silence Therapeutics, and of course, the support of our FH family partners, families who have stepped up to really support the FH Foundation and our awareness, education, and research efforts. Big thanks to all of them. So tonight we get to hear from Dr. Khandelwal, and I'm just so pleased. It's such an important topic, and thank you for being here, and I'll hand it over to you.
Thank you, Kat. I am very pleased to be here today and talk about something that's very near and dear to my heart. I'm hoping to provide a very basic framework for lipoprotein A so that the panelists and the participants can understand its importance. LPA has definitely had an impact in my personal life, and I suspect many of yours as well. So I do want to applaud you for taking the time to learn more and empower yourself about this condition. I will talk briefly about what LPA is, what's considered high, and what risks are associated with having high LPA. I will also talk about who should get an LPA test and what to do should you have high LPA. But my hope is that I can talk briefly and have plenty of time in the end for answering your questions. Next slide, please. And before we get into LPA, I do want to just take a step back and make sure that everyone understands what their lipid panel means. So when you go to your primary care doctor for your annual wellness visit, they may order something called a lipid panel or a cholesterol panel. This often will have a total cholesterol, which is calculated for you based on the three components mentioned here, the triglycerides, the HDL, and the LDL cholesterol. So I want to make it clear that unless you are specifically asking for lipoprotein A to be measured as a separate test, it will not be reported in a traditional lipid panel. Next slide, please. So what is lipoprotein A? You've seen us name it a couple different things, you know, LPA, Lp(a), lipoprotein A. It's all the same thing, just the names are used interchangeably. And it's a cholesterol that was first described in 1963. And to date, we still don't know what purpose it really serves. There are some theories thinking that it's related to perhaps childbirth and containing bleeding, but as of right now, there's no definitive data as to what purpose this protein really serves. We know it's synthesized in the liver, and we know that the the values in your bloodstream are largely genetically determined. And so I want to focus your attention on go back. Yeah, so I want to look at the molecular structure here a little bit. And so some have described LPA as LDL with a twist. I really like that analogy, where you can see the central core of the LPA molecule is still the LDL particle. It's got the ApoB protein around it, and that confers a atherosclerotic property, okay? But in addition to LDL, it's got these other features. So you can see these little kringles going around the side. Looks almost like a Danish pastry. That's known as ApoA, which is a protein that can actually confer a thrombotic risk as well as the atherosclerotic risk. And then in addition to that, on the top right, you'll see a spiky circle. That's the oxidized phospholipid. And this actually confers an inflammatory component to the molecule as well. So though it is LDL with a twist, it's kind of, I find it a more dangerous molecule in some regards. Next slide, please. So just to reiterate, high lipoprotein A, it's an important genetic risk factor for heart attacks and strokes. And it's actually very common. 1 in 5 people worldwide have this. And in fact, if you go to certain areas in the African continent, it can be as high as 1 in 3. If you look at ethnicities like South Asian population, it can be as high as 1 in 4. And actually, if you look at the FH Foundation or the FH population, it can be as high as 1 in 3. So though this is a very common condition, the way that it manifests itself can be quite variable and individual. So how does LPA increase risk for cardiovascular disease? So I'm going to go back to that structure that we just briefly talked about, which is you've got this LDL core, which is very, very pro-atherogenic, and you've got this oxidized phospholipid, which is inflaming your blood vessels, and then you've got this ApoA that's clotting them. So it really kind of is a setup for having a vascular event. So it can manifest itself via having an ischemic stroke. It's implicated in aortic valve stenosis. It is known to be associated with heart attack and also peripheral arterial disease. What is a normal level of Lp(a)? So when you're reading your report, it's very important to pay attention to the units in which it's being reported. So we consider a normal LPA less than 30 milligrams per deciliter or 75 nanomoles per liter. I'm not going to go into the details of how these tests are run, but there are 2 different ways to report it. And based on the American Heart Association and American College of Cardiology, we agree that the elevated Lp(a) is greater than 50 milligrams per deciliter or 125 nanomoles per liter. Next slide, please. So who should be tested? Well, if you ask me, I obviously am a little bit biased, but I do think everyone deserves a test at least once in their lifetime. But if you go to our kind of governing bodies and different societies, they all agree that there is a role for lipoprotein A testing for those patients who are at high risk. In fact, the European Society of Cardiology will actually has gone as far to note that an LPA that's greater than 180 milligrams per deciliter is an equivalent, is defined as a risk equivalent for as FH. And so I think it is important to be tested. And I think clinically, I utilize it if a patient tells me that their family, that their family history has a high Lp(a), or if a patient has cardiovascular disease that is out of proportion to their other risk factors, or potentially as well if they're having recurrent events and if they're high risk. Next slide, please. So do people need to be tested over and over again? Probably not. We know that we reach our peak adult LPA level generally by the age of 5, and that level remains stable for most of our adult life. There are some exceptions. So for the women in the audience, we know that menopause changes many things. LPA is one of them. So we know that estrogen can lower LPA, and with menopause, estrogen does decline. And so that may result in patients seeing as much as a 20% increase in their LPA. The other time that we can see a dramatic change is in an acute illness. LPA is known as a acute phase reactant, and this means that it can rise significantly in conditions of physical stress, such as a major surgery, a heart attack, a critical illness. So another thing to think about is if my patient is coming in with a heart attack, that may not be the best time to measure this value. Perhaps it's better measured when they are seen in the outpatient setting once they've calmed down from that acute event. So we are very lucky that we now have ICD-10 codes for this condition. So you may see this reflected on your medical record. And so I think this is a huge win for our field, because in the future, this will help us better delineate the population that we are studying. So you may see these codes. I did note that LPA is inherited. And the way that I want you to kind of take away from this is that if you are afflicted with elevated LPA, your children have a 50% chance of inheriting it. And so it is, again, a very common disease, and it is inherited in what some say is an autosomal dominant fashion. Next slide, please. So what can you do if you have an elevated Lp(a)? So what we do in our clinic is to make sure that all of their other risk factors are under control. So if you do have a high LPA, the most important preventative treatment is to make sure all of your other cardiovascular risk factors are really well controlled, and especially your LDL. We know that there are many new treatments in development, but I want to reiterate that there's currently no LPA treatment that has been shown to prevent heart attacks or strokes. So when I spoke about managing all of our risk factors for heart attack and stroke, I think it's extremely important to kind of go through what those are. So number one, managing our cholesterol overall. We know that driving that LDL as low as we can is extremely important. We know that making sure that all our patients follow a heart healthy diet, one enriched with plants and vegetables based, avoiding saturated fat if possible. We ask that they really manage their blood glucose very well and make sure they're on proper therapies if they're diabetic. We ask our patients to maintain a healthy weight. So keeping a BMI less than 25 is extremely important. And in fact, in our South Asian patients, we have lower targets because we know even at normal body mass index, South Asians tend to have more glycemic issues. It's extremely important to make sure patients are keeping an eye on their blood pressure, and if they have high blood pressure, that it is treated to their goal. We encourage regular exercise, 150 minutes of aerobic exercise per week, as per the American Heart Association. We also ask that if they're trying to improve your cardiovascular condition, to try to even increase that up to 300 if possible. We really ask people to refrain from smoking or vaping, which is becoming an increasingly large issue amongst our younger population. And actually, we are very lucky to kind of work in a multidisciplinary fashion to work on emerging risk factors. So if patients have known autoimmune disease, making sure that's controlled. If patients have a known history of depression, making sure that's controlled. If patients have a known history of cancer therapies that are cardiotoxic, or if they have a history of pregnancy, adverse pregnancy outcomes, making sure that really all their risk factors are being watched very carefully. And so even though LPA may be elevated and you may not be able to entirely control that value, there are several other things that can really reduce your risk of heart attack and stroke. There are some medications that have been described to lower LPA. So with regards to diet, you know, overall, there has not been any good study to show that there is a diet that can really significantly reduce LPA. Some have said that there's a small signal for a saturated fat diet might lower it slightly, but that is not something that I routinely recommend. And in fact, I think it can have potentially dangerous effects on a patient's LDL. So there is no specific diet that I would recommend. You know, for statins, we know that it can increase the LPA by about 10 to 15%. But as a community, I think we largely agree that the benefit of lowering that LDL for most patients will outweigh that small elevated LPA change. But again, I'm speaking broadly. We know that Zetia and bempedoic acid really don't have a significant effect on lipoprotein A. And we know that some of these other agents can lower it anywhere from 15 to 20%, and with apheresis as much as 35%. But I'll talk about that on the subsequent slides. So I spoke about estrogen briefly. We know that it lowers LPA, but we also know from several studies, including the Heart and Estrogen Progesterone Replacement Study and the Women's Health Initiative, that hormone replacement increased events such as breast cancer, thrombosis, and stroke. So estrogen is not recommended to lower LPA. And in fact, if you think back to that molecule and you think of the APOA component of it, which also, confers some thrombotic risk, and then you give someone an agent like estrogen, you're really setting them up potentially for a dangerous situation. So it is not something that I routinely do. And then with regards to niacin, there are several practitioners and providers who do utilize niacin, but we know it can reduce LPA by about 20%. But overall, there was not a significant benefit found in patients with high LPA if their LDL was at control with a statin. So there also are some side effects with niacin, so it has to be used in the right context. And so it can increase the blood glucose, it can increase the risk of GI bleeding, as well as gout. And then PCSK9s are have been game-changing for FH. The two on the market, the evolocumab and alirocumab, both lower LPA by 15 to 30%. Two of the major outcome studies for PCSK9 inhibitors, including FOURIER and Odyssey outcomes, they did show that the LPA reduction could have contributed to the ability to reduce the cardiovascular events in these trials. So PCSK9 inhibitors, as of right now, are not FDA approved for LPA reduction, but we do know that they to date have some of the most dramatic effects in LPA. And then we can't talk about therapies without talking about apheresis. It is the only FDA approved therapy for lowering LPA. And here we have a patient hooked up to a machine. It is a commitment for the patient. And we'll go to the next slide. And with regards to the groups that are approved for apheresis, I'm going to draw your attention to the group D, which is the functional hypercholesterolemic patients with LDL-C greater than 100 milligrams per deciliter and LPA that's greater than 60 milligrams per deciliter. And they have to have documented coronary artery disease or peripheral arterial disease. So what's on the horizon, the upcoming clinical trials? I'm very excited about this, but we'll go to the next slide, actually. The one thing I just want to briefly talk about is, when we talk about DNA, RNA, and protein, okay, we have DNA, which is our blueprint, that then transcribes into it like an operational plan with the RNA. And then that translates into the protein that then works on receptors. And to date, most of our cardiovascular drugs have worked on that protein or on that receptor. What's very exciting and very elegant with some of these newer therapies that are being studied is they're working upstream from that. So they will be working on mostly kind of either the translation to the mRNA or on the RNA itself to actually reduce the production of the offending protein. And that design is quite elegant in that it can be very specific to the protein. And some of the technology they've used has decreased the amount of drug that's required to enter the system to have a very dramatic effect. And so, the three agents you may have heard of are, first is pelacarsen, which is also known as TQJ230. It's probably the furthest along and being developed by Novartis. It's currently in phase 3 trials. And then we also have olpasiran, also known as AMG 890. It's a small RNA molecule. Again, I think it's in phase 2 now, it's being developed by Amgen. And the third would be SLN 360, which again is a small interfering RNA, and it's being developed by Silence Therapeutics. If these three agents prove to be safe and effective in reducing events, we may be able to have a treatment on the market in as soon as 5 years. I mean, that's very exciting for those of us who have been taking care of these patients for some time. So with that, I'm going to hand it back over to Kat to share a little bit more about what resources are available.
Thank you, Dr. Khandelwal. That was really excellent. Such a great introduction to Lp(a), and thank you so much. We at the FH Foundation, we have a website where you can find more information on Lp(a), including some of our resources, like a link to our online support group, additional webinars like our Lp(a) 101 that was presented by Dr. Mary McGowan, who's the Chief Medical Officer at the FH Foundation. So that's like the next level of Lp(a) education, and many other resources there. And we welcome you to please visit the website and join our online discussion group so you can hear from others who have elevated Lp(a). On that website, we also have a place you'll find where you can search the clinical trials, and you can find out more about what is in clinical trials, what phase are they in, do they have a site near you, and it's all set up to search for those trials right there on the website, and it's linked to the clinicaltrials.gov, so it has the most up-to-date information on clinical trials for Lp(a), but also for other cholesterol-related conditions. And finally, while you're entering your questions, we are ready to answer your questions that you put into the Q&A. I invite you to put your questions there. But we also want to ask, for your support. Your support helps make programs like these possible, and we are so grateful for everybody who supports the FH Foundation. So if you would like to make a donation and show that support, we invite you to please visit the fhfoundation.org and click on the donate button. So let's get to the questions. And I think we can probably release the slides, and hopefully you're all just seeing Dr. Khandelwal and I, and we've already had some really terrific questions come in. One of the questions is in the context of, I think it's a great question, in the context of somebody who's high risk for cardiovascular disease versus low risk, and there's high Lp(a) in those two contexts. How do you think about the LDL target or threshold?
That's a very good question. I think that when we have multiple different things that contribute to cardiovascular risk, you have to take the biggest bang for your buck. And LDL is still a major driver. So, I mean, to me, I personally will try to kind of the lower the better for LDL, and I still will prioritize that.
Okay, and so what would you say? I mean, I know that the guidelines say if you have cardiovascular disease already, you want your LDL to be below 70. If you don't yet have cardiovascular disease, the cholesterol guideline says you want your LDL to be below 100. Are you still going for that in the context of elevated Lp(a)?
I am. I'm still following those guidelines, but if I can do marginal lifestyle interventions to bring them even lower, I will do that.
Okay. So I think a great question, could high Lp(a) be a cause of PE, which I think is pulmonary embolism? And I wonder also if I can put that question together with, how should we be thinking about high Lp(a) in the context of COVID? Is it fair to ask them together, or you can choose not to answer together?
Yeah, no, it's fine. I think that obviously we're all learning a lot about COVID specifically, and kind of we know that there is already this increasing clotting that's happening there. I think that I follow kind of Dr. Samikis's feelings about this, who's obviously very well established in LPA, and I think that there may be a role with that. And I think that in terms of treatment, you still have to kind of go based on the guidelines for PE and anticoagulation. In terms of how much of a role is there, that I don't think I can answer with a precise number.
Okay. I think one thing that's really helpful to talk about is there's the sort of what's normal, and you shared that for what is a normal Lp(a) number below. I'll ask you to repeat it so I don't get it wrong. And then there's like a small sort of above normal, and then there's high, but then some people seem to have much higher numbers. Is there anything you can say about when how do you understand those higher numbers? Is there some point at which you worry even more? How should people put their own numbers into context? If it's, somebody saying their Lp(a) is over 600.
Yeah. So, I mean, I think that less than 30 milligrams per deciliter or 75 nanomoles per liter is kind of what we accept as normal range for LPA. Traditionally speaking, when you are, 2 or 3 standard deviations away from the mean, your risk is likely much higher than that of right around kind of the abnormalities. So if you're at the far ends, and the European Society guideline kind of indicated this, if you're at a high end with regards to the LPA, your risk is likely significant.
So the higher the Lp(a), unfortunately, the higher the risk.
Yeah, and specifically, like, when you're looking at how far you are away from the mean. So some of these thresholds that were considered abnormal were also developed to be, greater than 80%, 80th percentile or higher.
So sort of the population, 20% of the population, what are their numbers? And I know I think it's safe to say, right, that we're still learning a lot about Lp(a). We don't know nearly as much as we might about LDL, for example. So I think it's one of the reasons we put the medical disclaimer up there also, right, is that things change, we're learning, and we will learn more as we go. I think there's another great question about you talked about the risks in women. One interesting question about the role of estrogen is some birth control pills have estrogen in them. Could those impact the Lp(a) number, and would you recommend testing Lp(a) before you start birth control pills so that you have a baseline?
That's a very interesting question, actually. I think that it's personally, I feel that everyone should have already had their LPA tested. So the answer would have been yes. But if you had not already had it done, then it's very reasonable before going on estrogen to see what your baseline values are.
Okay. Are you able to answer this? Do we know why statins increase LP little a?
I don't know that I can answer that um, with a specific mechanism. I know that I don't know. I saw Mary on this call, so maybe she might feel more comfortable. But I think that we know that it increases it a little bit, and I don't know what we know the exact mechanism.
Okay. But again, to reiterate, the slight increase does not outweigh the benefit of taking the statin and lowering the LDL. That's the current understanding. Is that correct?
Yeah, and just one more thing. I mean, with statins, lowering the LDL is just one component of their pleiotropic effects, right? I mean, they have a lot of vascular effects that are beneficial as well. So that small increase in LPA, we feel, as just generally speaking, is not worth worrying about when you have some of the other benefits that come with statins, including lowering the LDL, the endothelial function that it protects as well.
Okay. And maybe pleiotropic, maybe not everybody would know.
The variety of benefits that come from statins outweigh the small risk for most people of the small elevation in LPA.
Okay, that's very helpful, very clear message. I think there are a lot of questions about COVID and the potential effect on LP little a of, I would say, I think one question is about if you have COVID, is there an effect on the LP little a? And then the other question is there anything about the vaccine that you recommend in the context of elevated LP little a?
I think with COVID, it's a little bit of uncharted waters. So I can tell you what my personal feeling is, which is that if you are in an acute illness, we know that LPA is an acute phase reactant, so it might be slightly elevated. With regards to vaccination, I follow what the CDC says, and I do believe that regardless of LPA status, that people should be vaccinated unless they have a major contraindication for it.
Thank you. And I'll share that on the FH Foundation website, we have resources that are specific to COVID, including several webinars, but also a letter that you can take to the ER if hopefully it won't happen, but explaining some of your risk, and so that's a letter that anybody can download and take with them. We also have a paper out from the FH Foundation that shows the increased risk of heart attacks in people who have contract COVID infections and have FH, whether it's diagnosed or not. So I think I'm so glad people are asking questions about that, because it's such an important topic. One person asked about what can be done to move things along when it comes to research in new therapies, and I guess one answer might be to look to see if you can join a clinical trial. But somebody was saying that they tried to join a clinical trial, but they had a hard time getting in. Any advice that you have, or any thoughts on joining clinical trials for elevated LP little a?
Yeah, I mean, in general, I would say that to advance the field requires a couple things. Number one is awareness. And so by attending webinars and learning more about the condition, number one, that's important, because it shows companies that conduct these clinical trials that this matters. And so they are interested in doing things to solve this problem. With regards to enrollment, it's not easy to participate in these trials. We've conducted several of them at my institution, from phase 2, phase 3 trials, and getting into them can be quite hard. The criteria can be quite challenging as well. But I hope that people will continue to try to participate. Particularly, we have a large barrier with underrepresented minorities and women for a variety of reasons, because of the number of visits, because they have, work, whatever the thing. So moving the field along includes participating in these trials, having a voice, participating in patient advocacy groups, and really making sure that these trials are poised to enroll many people and not just a very specific patient population.
I think that's such an important message. And while, of course, by definition, right, the drug is being tested for safety and efficacy, and trials are very, are designed to be as careful as possible, but you're certainly, it's a clinical trial. It's not an approved drug. But I will say that my understanding is that is one of the biggest expenses and the biggest time commitment is how long it takes to enroll the number of people that need to be enrolled in these trials, and they have to be quite large trials. So I'm glad we have the chance to raise awareness that there are trials and that people have the chance to at least think about it and talk to their doctor and make a decision that's right for them. We also, I would say, on the FH Foundation website, I think we have this great explanation of the phases of trials, which I found fascinating, and I hope others do also. I love this question about Dr. Khandelwal. I wonder what your thoughts are, why you think Lp(a) testing is not yet routine. Why isn't it part of a lipid panel? What are some of the elements that you think play into that?
I think that one is just awareness. Number one is just awareness. I think that there are still a lot of doctors and nurse practitioners and advanced care providers that don't even know the importance of elevated Lp(a). So one is knowledge and awareness. Secondarily, I mean, I know this sounds a little bit jaded, but I do think that when you identify something and you know that there are treatments in the pipeline, insurance companies may not have the most incentive to identify these patients. And that's maybe my jaded side saying that, but I think that's probably another component of it. I think I wish that it was more readily available, and honestly, in other parts of the world, people can just go to a lab and pay out of pocket and get things done. And I wish sometimes things like that were available in this country.
Mm-hmm. I do, and actually, for some tests, that is becoming possible. It's I think that that's a really interesting development. Hopefully, Lp(a) will be one of those, but that may also contribute to disparities in who gets tested and who doesn't. And certainly, the FH Foundation will be raised, as we are right now, right, raising awareness of the need for people to know what their Lp(a) number is. I think the other element I've heard people talk about is that if there are no specific treatments for most people who have elevated Lp(a), then maybe we don't test for it because we don't have anything that we can do about it. But I'll share, and I'd love to hear your perspective about your patients, that we hear from individuals and families who've been profoundly affected by the impact of heart disease and stroke and premature death from where the only risk factor was a very elevated Lp(a). And they want to know, because that helps you understand your risk and what might be going on. And if you go to the hospital with chest pain and no other risk factors, that's an important piece of information. So sometimes just knowing is really powerful, and I think stands on its own as a reason to test.
Yeah, and I mean, I agree with you. That's traditionally been like, a lot of the insurance companies will say that, oh, it's an experimental test. And then, I mean, they'll say that because there's no treatment, like you said, that, what's the value in testing it? But as a provider, I can tell you there's a huge value in testing it. Not only do patients modify their day-to-day behavior when they hear about this risk factor, but I mean, at least here in the Bay, I have a fairly large cohort of young patients with heart attacks, like less than, they're in their 30s and 40s, and their only risk factor was Lp(a). And so had they known that, going in, maybe it could have been identified sooner. They come to me usually after the fact, but I think that having that knowledge is extremely important, especially because I don't think it's actually that expensive a test to
Right.
run.
It's not. I will caution people to find out how much it is before you get it done, because your insurance company might have a preference for the lab. We've heard people get burned that way. I want to make sure everybody knows when we talk about FH, we're talking about familial hypercholesterolemia, which is a genetic condition that affects 1 in 250 people worldwide and causes high LDL from birth. And then, of course, Dr. Khandelwal is talking predominantly about elevated lipoprotein A or LP little a. And I know you had that slide that showed, 1 in 5 people have elevated LP little a, but it seems more common in people with FH or in some other populations. But I think also important to say that there are lots of people who do not have FH, do not have elevated LDLs when you do the screen, right? But the LP little a can be elevated. Is that correct?
Yeah, that's exactly correct. And I guess that's what I'm getting at, is that by knowing that they had an LP little a, they might then look at their diet, their exercise. They may not have other things that would have otherwise brought them into the healthcare system to kind of modify their risk. So a large majority of these patients I was describing actually had elevated LP(a). They did not have an elevated LDL.
Mm-hmm. So if you didn't specifically, as you said right at the outset, if you didn't specifically order that, it's a blood test, it's not the genetic test. It's just a
Blood test.
test. Then you wouldn't know the LP little a. There are just so many great questions here. I'm trying to get to as many as I can. I don't, what are your thoughts on testing and management of elevated LP little a in children? So testing, and also if it's found to be very high, what can be done at this point?
Yeah, so I'm not a pediatrician. So with that disclaimer, I will tell you, I do think that all people deserve an LPA at some point in their life. And if I talk to some of my pediatric neurology colleagues, they've seen some pretty devastating outcomes in young children with stroke with elevated LP(a). So do I think it should be done? I do think it should be done, but I think it needs to be very carefully thought as to how kind of the cascade or kind of the screening should be done, because especially at very young ages, translating that information to a young mind is also has to be done very carefully.
Yeah.
So I think that has to be thought how to be done with pediatricians, neurologists who take care of these young kids very thoughtfully.
I love that you said that. I think it's so important. You never know what kids are hearing, even if you know what you're saying, but we don't necessarily know what they're hearing. And so it's important how we talk about these risk factors for young kids. I would say, I think one thing that people could do is to find a lipid specialist. And on the FH Foundation's website, again, we have a map where you can put in your zip code and look for a lipid specialist if this is something that you need to really talk to an expert about. And I think a pediatric lipid specialist we have those listed as well. And if you have any trouble finding somebody in your area, then please write to the FH Foundation at info@thefhfoundation.org, and we will we'll call around and find somebody for you. And somebody did ask Dr. Khandelwal how they can make an appointment with you. I'm assuming they call Stanford and visit the website and look for you.
Yeah,
You have some lucky patients. So as I look through the questions and do my best to get to them all, any thoughts that you have?
I saw, I was trying to keep up as well. There's so many, I was having a hard time, but I think there was one question about, do I recommend programs that focus on reducing other controllable risk factors? And I do, as a cardiologist, we don't just have one treatment strategy, right? We have an armamentarium. and we have to fight on all the different fronts. So yes, LPA being elevated is a big issue, but we have to make sure that we're taking care of the blood pressure and the obesity. And I mean, we have behavioral psychologists working with our patients for weight loss and other untreated risk factors. So I think it's extremely important. That's what we can do right now.
That's great. So I think, well, we have some questions about lipoprotein apheresis and its role in it lowers LDL and lowers Lp(a). Any thoughts on apheresis?
Yeah, so there actually, I think it's on your website as well, Kat. There's ways to locate centers that will do apheresis for patients with elevated lipoprotein A and a known documented cardiovascular disease or PAD, as I had mentioned. And it is a commitment for the patient because they're coming in to get the apheresis every couple weeks. And we do notice that there's kind of this this overall downtrending reduction in the LPA. So there should be centers. I don't know where the person who asked that question lives, but I at least from the FH Foundation, you can go there and see, find a list of places that will do it near you, at least for the Bay Area.
Thank you. You took the words right out of my mouth. I think it's interesting to me how high these numbers can be. Interesting is probably an understatement. Some have posted that their numbers are over 600. Somebody posted over 1,200 milligrams per liter. Would you recommend that somebody who has a level that high really should make sure they find somebody who's especially focused on
a lipidologist? Yes, for sure.
And I think one of the things you talked about a little bit, I would love for you to expand on it, is that there are different populations, like Lp(a) might manifest differently. The effects of high Lp(a) might manifest differently in different populations, men and women, South Asians, you mentioned. Could you talk about that a little more?
Yes, I'm happy to talk about that. So I didn't go into the details of something called isoforms, meaning kind of the size of the lipoprotein. But we can kind of simplify this a little bit and say that if you have like a very large isoform, you may have lower levels. And then there are certain populations that actually have kind of the smaller isoforms that are very readily produced and come out of the liver. And what we at least have seen here clinically is that, for instance, South Asians are a particularly high risk population in this area. And what I've seen, at least in my practice, is that oftentimes they may not have other traditional risk factors. They may not be overweight. They may not actually have diabetes or even be insulin resistant, but their LPAs will be in that 200, quite high range. And then because they otherwise were never identified by the medical system, they come into the emergency room with chest pain. They're young, they're sent home diagnosed with anxiety, and then they come back in with a massive event. And when the evaluation is done, you see that they had a large heart attack, and the only risk factor was LPA. So I think that the demonstration for each individual is very heterogeneous or very different. So just because it's high doesn't mean my high and your high may not be the same clinical manifestation. But the goal of at least me talking to folks tonight is to know that if it's high, you should be talking to someone who can look at you individually and tell you what are the things that you most should be worried about in your particular situation, if that makes sense.
I think that makes a lot of sense. And I think also that we've tried to make this a very introductory, very, get to know the basics. about LP little a, but LP little a is a complex molecule. And so I would point, if people really want to get into more detail on that and the number of Kringles and all of that, we do have, as I said, this other webinar, LP little a 101, where we go into more detail. I think one area to touch on before we go is about the diagnostic tests, because people are often wondering, like, what's going on? How is this really, how do I know how this is impacting me, short of having, hopefully not having an event. So the carotid, the ultrasound, or calcium score. If you have a 0 calcium score, should you stop worrying about your elevated LP little a? And what other kinds of tests people might consider?
Yeah, so I actually really like that question. I think it's an important thing to understand. So at least if you're going to a prevention specialist or someone who is really focused on risk stratification in patients with high LPA, they're going to look at kind of the entire vascular bed, and they're going to talk to the patient. So for instance, a calcium score is something that we frequently use in our intermediate risk, middle-age patients to try to help stratify them into like a lower or higher risk category. So if I am a 50-year-old white woman and have an LPA that's very, very high, I lead my life very, very clean, no other issues. And then you come to my office and we talk about things, we might say, okay, well, let's look at a calcium score and see what that shows. And that will give us a surrogate. We can kind of put that calcium score on a well-validated model and see what percentile that person is in. So are they 0, where they're better than most people their age, or are they at 100, 200 or 300, so much worse off than most people their age? And then kind of integrating that into providing an individual risk assessment for the patient. There's a lot of work being done on more advanced risk stratification with genetic scores and things like that too, but that's still kind of work being done in the future. For me, I don't just say, okay, well, if your LPA is high, don't worry, because you do have to worry a little bit whether other tests are positive or not. You have this risk factor. Using the test in the right context is also very important, because a lot of times people will get a 0 calcium score and say, I'm good. And that is absolutely not necessarily true at all. As we know, calcium scores only look for a specific type of plaque, a calcified plaque. It does not identify soft plaque. And there, again, are certain populations that have lower calcium scores, like South Asians. So I don't necessarily dismiss risk if some of these other tests are not very abnormal, but it's just added information. The other things that we can do are looking at the carotids to look at the thickness of the inner lining of the artery, because that also can give us a little bit more information about the person's risk. We can look at the abdominal aorta to look, for plaque buildup there too. But the things that a lot of these things are done through like third-party vendors, because a lot of them may or may not be covered by insurance. So it's a little tricky, but there are a lot of different tests that can be done. But the key is to understanding the risk more than just getting a lot of tests.
So sort of they're pieces of the puzzle, but no one piece tells you everything that you need to know. I think that's really helpful. So I think that we are at the end of our time, and I want to just take a minute to say thank you so much, Dr. Khandelwal. It's really, I've learned a lot. I know everybody attending has learned a lot, and we just really appreciate you and appreciate all the attendees. We've had some amazing questions, and I'm sorry for the ones that I didn't get to. And for everybody who might have joined late, or who wants to tell their friends and family about this webinar, it is recorded and it will be available on the FH Foundation website in a week or two. And if since you're here, you're registered, you'll get a notice about that. And anybody can join at any time and watch the video back. And we hope that you will visit the website and come back for more. We'll have more information, more webinars, more educational materials. Thanks so much.
It's my pleasure. Again, thank you for inviting me to share my knowledge on this condition, and to all the attendees. It's really important to improve awareness. So thank you for taking the time out of your day to learn.
I agree. Thank you.